Hello, everyone, and thank you for joining us for this webinar, Considerations for Designing Fall Prevention and Physical Literacy Programs for South Asian Older Women. I'm Shelley Dallas Smith, Finding Balance Project Coordinator from the Injury Prevention Center, and I will be your host today. We are pleased to offer you this excellent learning opportunity with our speakers from the University of Alberta, Department of Physical Therapy, and Faculty of Nursing. They will speak to considerations and adaptations from their Edmonton community-based fall prevention program that is culturally sensitive for South Asian older women using the STRONG program and co-design process. The Injury Prevention Center and the University of Alberta are primarily located on lands that are now known as part of Treaties 6, 7, and 8 and homeland of the Métis. The University of Alberta is home to a diverse and welcoming community of over 1,900 students from across the country. We are proud to be the only university in Canada with a Faculty of Native Studies. We respect the sovereignty, lands, histories, and languages, knowledge systems, and culture of all First Nations, Métis, and Inuit nations. This webinar will be recorded, your microphone will be muted, and your camera will be disabled for the entire webinar. Through the chat function, you will be able to ask the organizers any technical issues that you may be having. At the end of the presentation, there will be time for questions, so please use the Q&A function for all of your questions, and a selection of these questions will be read out loud by myself. A survey will be posted in the chat at the end of the webinar. So it's my pleasure now to introduce our speakers for today. Sadaf Mirad is a doctoral student in the Faculty of Nursing, University of Alberta, and registered nurse with expertise in dementia care and immigrant health. Her research has included a focus on mobility in older adults, dementia in immigrant communities, and aging in place. Joe Nanda is a second-year master's physiotherapy student, University of Alberta as well, who has adapted falls prevention from the STRONG program to better meet the needs of the Edmonton South Asian older women's community. Also joining us to support the presenters are Professor Allison Jones from the Department of Physical Therapy, U of A, and Associate Professor Jordana Salma from the Faculty of Nursing, University of Alberta. Thank you all for being here, and Joe, you may now share your presentation, and we welcome Sadaf.
Hello, everyone. Can you hear me?
Sorry, technical difficulties.
No worries.
Yes, we can hear you. You're good.
Okay, can everybody see?
I think you have to expand the slide to the full screen.
Just the presenter view.
Yeah.
Is that
Presenter,
good?
presenter view. No, we're not seeing the presenter view.
We're seeing the slides. Yeah, good.
There you go.
Okay.
So welcome everyone, and sorry for the tech issues. My name is Sadaf Murad Qasim, and I'm a PhD candidate student at Faculty of Nursing, and Josna here is my colleague here, sharing today our consideration for designing a fall prevention program and physical literacy program for South Asian older women, which was a strong program study. We did it our South Asian women for almost 3 years, and this study is funded by CIHR, and my professor, Dr. Jordan and Dr. Allison, are PI and co-PI in this project. Next, please. I'll give you a little bit background about our research lab, IREA. So IREA is implementing research for equity in aging, and our research program focus on exploring and identifying the health and well-being challenges for immigrant older adults, and finding ways to address their healthcare needs, and finding cross-cultural and transnational dimensions to support their quality of aging. As we all know that in Canada, 23 to 30% of population are older immigrant, and most of these numbers are being expected projected to double by 2050, which is a really alarming sign. That means that are we ready to address their healthcare need? Are we addressed to make them socially acceptable and making them feel that we care for them? And we've seen, according to research, that most of the Canadian people who born and lived here are more healthier than those immigrants who come healthier from their countries. But when they move to Canada after a certain time, they see fall or decrease in their health status, which is called healthy immigrant effect, and which not only affect their physical health, but also in their mental health, and had created more health issues later in their quality of aging. So in IREA Lab, we are working with them, with the community, for them, and with them in terms of developing a program and responsive community-based network to support their aging need and address and making sure that their needs are being reciprocated and shared to people at healthcare and community and policy level, and using their strength in a way that they feel that we are part of Canadian culture and people value us and we do matter. Next slide, please. This is just a small infographics we created out of our research. We did a three-phase research, and out of that research, we found that there are certain ways that ethnic community and immigrant community, especially in South Asian culture, people and especially women like to adapt physical literacy and exercises in a certain way if you provided them in culturally linguistic sense where their language is involved, they feel culturally safe, and they feel that their stories matter, and how you buy in their stories, their experience, in a way that they understand that why exercise is important, why having physical literacy is important, why caring for your health is important. Again, using a strength-based approach where we focus on their strength rather than thinking, oh, you're older, or you're migrant, or you have language issues. Rather than using that deficit-based model, we use their strength, that you have lots of strength. You are bringing lots of richness to this community. You are source of care for your family, because some of your family members are able to work because you're taking care of their kids. So using that strength-based lens and family-centered approach, we tied in our physical literacy program, so they feel that we need to be physically active and strong so we can support more our family. And then peer-to-peer champion, because most of them were learning a lot when the peers who look like them, talk like them, share their experience and tell them that how they adapted their lifestyle, and that make them that transition easy to move. And then another one, which is a really big one, is culturally safe myth busting on age and aging, because sometimes there's a stigma, there's culturally labeled based on aging and certain physical and mental health capabilities. So how you using a cultural lens in a way that it is safe to uh, address those myths, and telling them that you still need to take care of yourself, and people with older adults doesn't mean that you have to be sick. And then the major one, which I say, is the co-designing with the community to address what are their needs and what they want for us, so the program which we are delivering is sustainable and can owned by the community rather than the researchers. Next, please. In our research lab and in our most of our research project, we use the intersectionality lens, and I'm sure most of you know about intersectionality. It's a lot of work in immigrant communities have used the intersectional lens, but especially for older adults who come from racialized and refugees communities. They have multiple identities. Sometimes due to those marginalized identity, they suffer through not only the personal issue, but systematic issue and social issues, which create their health and their well-being more disparities for them. So in our lab, and in our research program, we are focusing on their lived experiences and using those lived experiences in the research and a practice in a way that inform the research and practice, and tell that what people are suffering and what they want rather than what we as a researcher think. And of course, using an intersectional lens come with the social justice lens, that whatever the outcome comes, it should have a social justice outcome that have implication in practice, and that can be addressed to address their needs and need to be implemented not just in practice but at policy level, so they feel that they are involved, they are inclusive, and they are welcome, and their voice does matter. And of course, when you're using an intersectional lens, it's always about commitment to reflexivity, because we all know that as a healthcare professional, as a researchers, as a professionals, we have more education that give us more power, and we feel more privilege in terms of someone who maybe have broken English, have financial issues, just moved as a refugee, have aging issue, and they feel like, oh, we don't know as you know. So using intersectional lens is to mean that telling them that you know more than us, because you have the rich lived experiences which we don't have. You know what's going on with you, which is creating more disparities for you. And how we as the researchers address that barrier so you feel more empowered and you feel that your voice matter and your voice is being inclusive, and you see the outcome in practice and in a policy way. Next. Using an intersectional lens is just an overview. What I said, that intersectionality look on lenses and how those multiple lenses can create disparities for individual, not at their personal level, but at the system level and structural level. And some of those disparities are done at the structural level, which had an impact at system level, which lead issue on their personal and socioeconomical level. So using intersectional lens mean that you are being aware that there are disparities at different level, and you need to address those disparities in terms of addressing and making their health priority and making solutions for their challenges. Next. So this is about our research project. The overarching goal of our research was to promote an outdoor mobility and enhance neighborhood walkability for racialized older immigrant women, especially those from South Asian community living in Edmonton, Canada. Our primary research question was, what are the racialized immigrant women experience of urban walkability, and how can we promote outdoor mobility in this population? And the sub questions aligned to that research project was like their experiences across seasons, winter versus summer, as we all know outside. Last week it was good to walk, and this week we can hardly go to outside. How do these experiences differ in subgroup of racialized women based on their ethnicity, their religion, their socioeconomic status, their age, their health status, and their basically their identity and their value in the family, because most of those women were the caregiver for their kids and grandkids. So how using those experiences make their walkability either empowered or either having some challenges in making sure that they go walk out or do some kind of exercise in physical way. And then we after this phase one, we got a lot of information from our participant, which lead to our phase two and phase three, where we co-design our research program with South Asian women in connection with community partners and community champion in a way to improve social connection, health literacy, and physical function of racialized older women. Next, please. So this was a little bit broad overview of our inclusion and exclusion criteria. Most of the women who were age 16 above from South Asian community who were able to walk at least the one block without using any supervision or walking aid were part of this research. Those who had two or more than two falls or had severe chronic issue which prevent them to walk outdoor were excluded at this time for our research. Next, please. So you can see beautifully the wave of our project, how it started and how we lead to phase three. So we started with a need assessment, which was our phase one, where we did interview almost 46 to 53 participants about their walkability and neighborhood in Edmonton and their barriers and what things help them and how they engage in their neighborhood and in terms of walkability and physical literacy. And from that, we learned a lot the needs and the gaps in the community, which inspired our phase two, which was a co-designing, in which we involved the senior women who were also the community champion, who were running some kind of community program, South Asian women in community. So those were the champions who involved in our program because they were already running the programs in the community. So they knew the people and they knew their problems. So they were the part of our community champion group, and with them we met every week week and co-design a program which we call a STRONG program. And STRONG means Senior Thriving, Reaching Out, and Growing a Program. So with them, we are creating a program which make them strong and give them information and knowledge about their health and physical literacy. And which was our phase 3, which was our interventional phase, where we partnership with our Indo-Canadian Women Association and our community champion, where we developed a program which was twice a week. 1 week was learning and 1 week was physiotherapy exercises, where community champion participants and facilitators were engaged collectively to identify what are their needs and how to improve their physical literacy and health knowledge. Next, please. So when we did our co-designing program, we found some top priorities from our participants and from our community champions and our peers. And these are some of this highlighted here, but some of which I like to highlight here is many of them were looking for companion. They were looking for someone who look like them, talk like them, or can understand their language so they can go walk with them. Most of them were doing indoor versus outdoor walking. There's few of them were saying, we are going in a Southgate Mall and walking there because we cannot walk outside. We feel scared to walk outside. So that was another thing kind of highlighted in our study. Another thing which we really was shocking for us that they like to sometime go in a park and see some people who are walking, and then they feel that engaged to walk outside. Sometimes they go in neighborhood just with their kids or grandkids. Like most of them were saying, we are going walk with our grandkids because they go to park and play and we walk around. So sometimes having a family or having a grandkid is a positive factor for them to go out and walk only if weather is good. Again, indoor socializing, some of them were saying we do meet with friends in cafe, we meet them inside, they come to our home, we go to their home because we can't go outside. Or most of them were saying we meet them in a religious places. This is where they do their spiritual practice and their socialization and gathering. The another one, which is major, I really wanted to highlight is transportation. Most of them were feeling that they are trapped because if kids take them from point A to point B, then they can go. Otherwise, they cannot do. They don't know how to drive. And sometimes they were saying, we want to go, we want to volunteer, but the bus stop is too far and we can't walk that far. And sometimes bus stop doesn't stop. So we can't run and catch them. So those were the challenges which most of the South Asian older women were sharing. Again, in terms of caregiver needs, most of them were saying that they are actually still a caregiver in a family. They were taking care of their grandkids. So their kids, their daughter-in-laws, their daughters can go and work outside. So they are still cooking, taking care of their kids, taking care of their spouse. So they are so busy in their caregiving role that they're still not retired. They're still working. Some of them were saying that family support really helped. Their kids encourage them to go walk out. The kids help them to support to go to the places where there's some kind of socialization or some kind of activities or rec centered. Some people say that they want to go out, but they use a walkability aids, and sometimes they feel scared to go out with the aids because our roads are not sometimes designed for older adults to walk properly. And then another one which related to weather was like winter, of course, and then poor air quality because at that time the air quality in the summer was very bad and some of them were not going outside due to the asthma and other health concern they had. Next, please. So with that, we came up with our interventional program, which is a strong program, which again is Senior Thriving, Reaching Out and Growing program. So in this program, we had 30 participants and 40 community champions. We did 2 sessions per week, and it was 8-week sessions in total. So every week, there was one session which was conducted over the Zoom, which is on the health education, which was led by an RN, which was I was the one who was leading this session. In this, we covered various topics such as bladder incontinence, such as fall prevention, such as brain health, which was all tied in with need of physical activity and importance of physical literacy and exercises. And then with that, every other on the Thursdays, they used to meet our physiotherapists who used to do exercise with them, which were focused on their mobility, their balance, and strength. And the good part about this program that all the sessions were delivered in Hindi and Urdu, which is most of the time their first language, and most of the time we use their cultural stories, we use their cultural saying, we use their strength as an older adult coming from South Asian community. So we use those examples to motivate and encourage them that you can still do it, you can do it. It's just you need to understand and change your mindset towards more positivity rather than thinking that, oh, I'm aged, I cannot do it. Like few of the participants were saying that we never knew that it is so important to walk outside. If I walk outside, I will never fall and I will be able to take care of my kids more. And one of the participants said that, oh, I need to be strong so I can help my daughter more in her household chores so she can go work. So using those examples were really helpful us to make this program sustainable and adaptable to their needs so they can do it when we are not there. And most of the exercise which we did with them, it was translated both in Urdu and English with the pictures so they can see if they cannot read it and they can perform those exercises. And every week they used to meet the physiotherapist and go over what they did last week. So that repeat back helped them a lot to identify if there was any mistake they were doing during that exercise. I would like to read this quote where one of the participants said that I feel stronger and I have less pain and I have more energy. The exercise session made a real difference for me. Next, please. So the core principle of our program, these are major four core principle of our program. Of course, this program was culturally responsive and culturally adaptive. Community defined success because community was the one who was telling that how they feel empowered, what are their needs, and how those needs need to be addressed in a way that can be adapted by them and that can be sustained by them. Most of the participants face real-time barrier in terms of discrimination, isolation, and limited access to resources. So simply having a dedicated time where they can come and chat and learn about their health needs and perform the exercises in a environment which was not punitive, which was not judgmental, and which was based on their stories and empowering them as an individual and as a human, make them a lot comfortable, and they started peer-to-peer role modeling and they started having more trust and engagement, and within 1 to 2 sessions we've seen that all of the sudden they started talking, they started making friends, exchanging their WhatsApp number. So that was defined a success for us, that they started mingling outside of their own world. That one of the participants I remember said that I came out of my house without my kid after 6 years. That was the biggest compliment for us. Again, being culturally responsive, as I said, and then using strength-based rather than deficit-based approach, that you have your own strength. You are taking care of your kids. So you matter, because if you're strong, your family, your kids can go to work. So using that angle helped them a lot to identify that why it is important and why it is important to be physically active and do certain kind of exercise, because some of them were fearful to do exercise because they had negative imagination and stigma related to exercise. So using those culturally and strength-based and family-centered approach help us to make them feel that exercise is important, and having some kind of physical exercise improve their balance, improve their strength, decrease their frailty, and make them more strong. And hence the strong program. And then of course family-centered approach, because most of the family was involved. They were picking them, they were dropping them, they were addressing the Zoom connectivity issues. So it was a collective approach with the family rather than just an individual participant. And now I'll give floor to my colleague Josna. Josna, you're mute. Joe, you're mute.
Okay, now it's good.
Oops.
All right, can everyone still see?
Yes.
Okay, perfect. Sorry about that. Thank you, Sadaf. All right, so while keeping in mind the core principles Sadaf just mentioned, I want to just go over a quick recap. Falls among older adults represent a major and growing public health concern. About 1/3 of older adults experience a fall each year, and among adults aged 70 years and older, fall prevalence ranges from 32 to 40%. In Canada, falls are the leading cause of injury-related hospitalizations and death among individuals 65 and plus, and with older adults projected to grow and comprise nearly a quarter of Canada's population by 2040, the health, social, and economic burden of falls is expected to increase substantially. These trends highlight the need for effective and inclusive fall prevention strategies. With that being said, it has been proven that fall prevention programs work. They have been proven to be effective in improving physical strength and function to reduce frailty and fall risk. Evidence consistently demonstrate that multifactorial fall risk assessment combined with a multidisciplinary team and intervention is one of the most effective prevention approaches. However, even single component exercise programs can meaningfully reduce fall risk by improving an individual's strength and balance. Education and public awareness initiatives further support independence and self-management among older adults. Together, these strategies form the foundation of contemporary fall prevention programs such as STEADY and Finding Balance. The STEADY was developed by the CDC. It provides standardized screening, assessment tools, and educational resources for both clinicians and patients. For fall preventions, it includes resources like checklists, footwear recommendations, and exercise resources. And Finding Balance is a program which is focused more on education and public awareness. It empowers older adults with strategies to reduce falls, covering topics like vision, sleep, nutrition, medication safety, and physical activity. Both programs are evidence-informed and valuable. However, they may not be able to fully meet the needs of a culturally diverse population without some adaptation. This is because research shows that fall prevention differs across racial and ethnic groups in Canada. Despite this diversity, many prevention programs remain culturally homogenous, which can reduce effectiveness, engagement, and participation. Like Sadaf highlighted earlier, cultural beliefs shape attitudes towards exercise, perceptions of aging and pain, family caregiving roles, and willingness to seek help. Without cultural sensitivity, even evidence-based programs may unintentionally exclude those most at risk. Culturally sensitive fall prevention is fundamentally an issue of health equity. Health inequities persist for South Asians as they are one of the largest racialized immigrant groups in Canada, with high ethnic, linguistic, and religious diversity. Among this population, immigrant South Asian older women experience a unique set of challenges, especially related to physical activity, which are shaped by gendered social roles, cultural norms and expectations, and life course experiences. Yet many health promotion interventions demonstrate limited reach, adoption, and sustainment due to insufficient attention to their lived experiences and structural barriers. So our goal is for programs to shift and reflect a participant's languages, their values, their lived experiences in order to foster that trust, increase participation, and improve adherence. In doing so, they can help reduce disparities in fall-related injury and disability among diverse older adult populations. So, culturally sensitive care begins with the assessment. It requires healthcare professionals to understand the participants' lived experiences, values, routines, and functional goals. This is where communication really matters. Open-ended questions allow an older adult to describe what activities are important to them. For example, they may really want to do more prayer, family meals, or community involvement. These conversations can help address any discrepancies while defining physical activity, exercise, and chores as well. Just in this research, a common topic came up that a lot of older adults weren't able to define physical activity, and they often associated doing daily tasks or activities of daily living and physical activity, or vice versa, or they said that nothing in their life was physical activity because it wasn't routine, it wasn't moderate to vigorous physical activity, or structured like an exercise. Purposeful communication can also help to uncover barriers such as modesty, language differences, or expectations around physical activity. It's also important to recognize that some older adults may minimize symptoms out of respect for authority or because they believe the functional decline is inevitable. aging is just a part of life, and whatever they're experiencing is just something that's supposed to happen. So the use of a strength-based approach would be beneficial to help shift this conversation towards empowerment. Both in existing research and the STRONG program, it is found that by focusing on what participants were already doing or could do, the participants and intervention team were able to build quicker and better rapport and support the participants to see new possibilities for themselves. Before moving on to the next slide, I just want you to see some examples of simple, culturally sensitive interview prompts. These questions normalize cultural practices and help clinicians understand the functionally relevant goals, such as getting up off the floor or walking safely indoors. The next move is to incorporate culturally relevant activities into existing programs. In many South Asian cultures, floor-based activities are part of daily life. So fall prevention programs should include safe floor transfer training, practice from mats or low stools, and modify techniques using gait aids or supports like chairs and walls so they can continue to do the activities that are important to them. Exercise should also be adapted to modest clothing norms such as long skirts, saris, or hijabs. Demonstrating exercises that can be done barefoot in slippers is also essential since many South Asian households don't wear shoes indoors. This challenges some of the internalized biases and continues to work with our strength-based approach, as we're not aiming to change or assimilate people's behaviors, but rather normalizing and incorporating their realities into the program. The next slide is about family involvements. As Sadaf mentioned, family involvement is central in many South Asian households, and including relatives can greatly improve program adherence. Family members can help with home safety checks, accompany walking routines, and learn how to support mobility safely. Designing programs that are flexible and family-centered can also reduce scheduling and transport conflicts and make participation easier. The STRONG program also highlighted the need for family buy-in in order for increased participation. One research team member stated that the family is incredibly protective of the older adult in their lives. They're asking what they're doing, how are they doing it, what can they expect, who's going on there, who's going to be there, etc. This makes navigating conversation and including family members of an older adult crucial for program participation. Though family involvement can be beneficial for increasing participation, there is also a factor of cultural norms and family duty, especially for immigrant South Asian older women who arrive in Canada for family reunification purposes. During interviews in the STRONG program, many of these women prioritize caregiving responsibilities for spouses and grandchildren, which hinders their engagement in physical activity outside the home and increases their risk for social isolation. Participants mentioned that they have spent their entire lives loving and nurturing their family, but never got to love themselves and never took out any time for themselves. One participant clearly identified their role and stated that, "I didn't attend the exercise session because I take care of my grandchildren. My daughter-in-law works, so I stay at home to look after the children. I'm very busy with childcare, cooking, and household responsibilities, which is why I couldn't find time to participate in the exercise sessions." Due to this difference in values and priorities, it would be beneficial to provide flexible interventions that can be adapted to a variety of lifestyles and commitments. For example, providing at-home educational materials in multiple different languages and more convenient meeting times during maybe out of school or out of work times, which would be a little bit easier. One participant even offered a solution stating that she would prefer this program to be fully online because it would be more convenient and easier to attend while she was taking care of her grandchildren, and she would be able to participate anytime at home. Another important factor for program interest, participation, and adherence was the involvement of community champions. In the STRONG program, these champions were trusted proxies who bridged the gap between the academic team and the community. They've promoted the program that encouraged participation, as participants were often hesitant to sign up at first unless they either knew somebody in the program, their friend was already a participant, or their family member encouraged them to join. These champions reinforced relational safety, which included respect for individuals' cultural and linguistic inclusion and recognition of lived experience embedded in familial and migration realities. Once the first session of the program began, early adopters of the program also served as ambassadors, encouraging their peers to participate. Many participants expressed feeling more connected and understood during this program when there was someone who looked and talked like them in the sessions. Even if they were not the only ones leading the classes. For example, using community champions as demonstrators or assistants in addition to participants could be beneficial to increase that relational safety and connectedness. Some other cultural adaptations include seasonal adaptation. It is especially important for newcomers in Canada as winter introduces many new fall risks. Offering home-based routines, multilingual video guides, and safe indoor walking options such as malls, temples, community centers can help participants remain active year-round. It is also important to increase digital literacy by teaching older adults how to use their phones, emergency contacts, or wearable fall detection devices to further increase safety when we can't achieve all our goals via prevention. Finally, the socioeconomic considerations must be addressed, as many older adults may face barriers to purchasing equipment, safe footwear, or transportation. Offering low-cost alternatives and connecting them with community programs is essential for equitable fall prevention. While these adaptations have proven to increase physical activity levels and fall prevention in older women of the South Asian population, our goal is to incorporate cultural sensitivity into finding balance through targeted adaptation rather than replacing existing programs. This includes providing multilingual translation, culturally representative imagery, family-centered education, inclusion of culturally meaningful movement practices such as dance, ceremony, or prayer-related mobility. Partnerships with community and faith organizations further enhance trust and accessibility. These are just a few of the examples of incorporating the aforementioned suggestions for program design and adaptation. To conclude, culturally tailored fall prevention is not simply about translation. It's about meaningful integration of participants' culture, cultural identities, values, and lived experiences. By adapting assessments, exercises, and education to reflect the realities of patients and address the structural and systemic barriers, healthcare professionals can promote dignity, empowerment, safety, and inclusion. Ultimately, culturally sensitive programs bridge the gap between clinical best practice and the cultural contexts that shape people's lives. When we honor these contexts, we support all older adults in staying steady, strong, and connected to the traditions they value. Lastly, I want to add a quick slide with some additional information you can access. This includes the contact information for Dr. Jordana Salma, Dr. Allison Jones, and Sadaf Murad, the developers of the STRONG program. If you have any questions after this presentation, feel free to contact them through these emails. It also contains a link to some additional sources, like the Implementing Research for Equity in Aging Lab, which was developed by Dr. Jordana Salma and is dedicated to improving the health and well-being of immigrant and racialized older adults in Canada. There is the link below it is just another one for the IREA and the current projects they're conducting. And lastly, there is a link for a systemic realist review about the effects of community group-based physical activity programs for immigrant older adults. Thank you, and please let us know if you have any questions.
Okay, I'll get you to stop sharing there. Great. Thank you so much. That was really interesting. Lots of information. I think lots of challenges and lots of learnings and lots of successes. Let's move on to the questions. I have one question here already from Tina, and the question is. Each a language question. Each session was delivered in both Hindu and Urdu. Are the languages very similar, such that one would understand the other, or the information was understood by some and then also stated again to be understood by others?
So the Urdu and Hindi, they are similar in listening, but different dialect in writing. So when you talk, it's same, totally the same. So, but there are certain words which are different in Hindi and Urdu. But we were fluent in both, so we were talking in using those both words, which make same sense in Urdu and Hindi, and Urdu and Hindi sound same in the speaking way. It's just the writing is different. So in answer to your question, yeah, they both are same when you speak, but just writing is a little different. And yeah, most of them understand because this is the language they sometimes talk in their home. And there was only two participants in our program who actually used to talk in English, but all other was talking in Hindi and Urdu. So, and they are same in speaking.
Great. Thank you, Sadaf. Um, any more questions out there? Feel free to type your question in the Q&A box if you have something you want to know more about. Any comments? Any questions? We'll give people just a few more minutes on that. I'm not seeing anything in the chat box either, which is good because we've asked you to put your questions in the Q&A box. I'm curious about the choice of you. I appreciate you acknowledging and using the Finding Balance resources, and we could certainly improve in the translation of resources, and we try and make sure that we've got kind of, I guess, examples, picture, visuals of things as best as we could that help reduce some of those barriers. So I'm wondering what led to the application of the STEADY program versus other possibilities, I guess.
Sorry. So what I'm understanding, you're asking the having different translation and having figure attached to it. What led to that decision? Or
Oh no, I was just saying I appreciate that.
okay.
Saying that's great. And when we produce our Finding Balance resources, we try and have lots of visuals because we know that we're missing the mark. We're not translating all of the resources into all of the, possible languages that we could, although we do our best with some of the kind of the basic resources that we have. So I appreciate the work that you're doing in that respect. And you have chosen STEADY as the exercise program. So I just wondered what led to that decision, just kind of like
Um,
maybe a literature
I
search of what is best practice.
I can talk about that.
Sure.
Steady is one of the more standardized practices, just like in
Yeah.
hospital settings and more AHS and, like I said, more standardized assessment tools. So it's very easy to implement in more of a larger population. I do have an example of also implementing the culturally sensitive to Steady. I just didn't think it was applicable to a Finding Balance presentation. But it's similar that you would alter the conversational styles and incorporate more narrative storytelling because a lot of the way they teach it is informative of Western approaches of like an individual who is educated made this program and you follow it word for word, and it doesn't
Hmm.
always follow that sort of format doesn't always fit into the learning styles of the South Asian population, or it just isn't applicable because A, they don't speak the same language, B, they don't know why it's important. There's the
Hmm.
same generational gap that we have amongst the older adults here. Like a lot of the people who are in their 60s or 70s don't know why exercise is important, why physical activities. The same generational gap exists in South Asian populations as well. So it's just bridging that gap and Steady as well, because though they are standardized, they don't fit a new standard or new cultural standard. And you would
Right.
also include environmental assessments. So because it's so standardized, it assumes that people all wear shoes at home. They all have equipment readily available that wouldn't make sense to have in a South Asian household. So we have to just alter tiny things like they're going to be wearing nothing at home, but what if we introduce indoor slippers? What are the criteria for that when you're giving footwear recommendations? What can they do to still do everything that they need to do at home? So they wouldn't, it's not good to wear shoes when you're praying, but it's a false risk to go down wearing socks in multiple times a day to do prayer and then getting up because it's just a slipping hazard. So can we incorporate maybe like slippers or something, or those recommendations that still abide by cultural practices into
Hmm.
their daily lives? So things like that would be a thing you could do for Steady because they give those pamphlets and those checklists that people can take at home.
Excellent. Good. Thank you. I appreciate Appreciate
I
your
Yeah.
also
answer.
just want to add on what Joe said, that when we did our phase one of the study, it was just to see their walkability in neighborhood, and we found that many of them were struggling to even understand what is the importance of doing exercise and what does mean exercise and
Hmm.
why they need to, because we are doing household work and that is exercise for them. They never been clear that exercise is something which you do and where your heart rate is increased and you have sweating, and then I'm like, oh, we never sweat in Canada. In Canada, you can never sweat. And I'm like, no, you can't. So, those were some gaps we find out. And then when we have participants coming for intervention sessions for exercises, most of them were never had their water bottles with them. So we were constantly telling them, like, you have to bring your water bottle, you have to wear your indoor slippers, you have to bring your runners, because they never had a concept of wearing your runners or going for exercise. So this was a very new thing for some of them because they never had that opportunity in their life due to whatever the socioeconomical challenges they have in their life. And then few of them were still doing exercises in the traditional clothes. So some of that can increase their risk of fall. So how can you bring little bit change in your wearing style so you can do certain mobility, then bend down? So it was lots of learning with the community that how to adopt things in a way so they understand that we need to do exercise, but how you can adapt it in a way that you can do it using your cultural preferences and your personal preferences.
Thank you.
And maybe to add on to that, from a delivery perspective, and looking at delivering falls prevention programs and such, it's being able to work with your class as well as being sensitive to those issues and being receptive to those issues. And I know, with when you have large groups and you're delivering a program, it's a little more challenging. And so maybe it also speaks to having more, having smaller groups that you can hear people's voices, hear their concerns, and adapt to their situation.
Yeah, I think it's really important to capture the voices, that lived experience, and hear the stories, and use storytelling as well as a learning opportunity, or learning opportunity of exploration, right? And thoughts. So yeah, there's certainly more considerations that need to be taken into account. And I think you guys did a really good job of doing that with this program. You really took the time to listen and to hear, and validate and understand the value of what people were saying as far as what those barriers and challenges, and just different, like the cultural differences, for sure. Actually, I hadn't given much thought to the multiple numbers of times a day with prayer, with getting on and off, up and down from the floor or a mat, and in relation to, we have our how to get up from a fall kind of resource, but in thinking that from with some cultural sensitivity, and in another context, there's certainly room for improvement with those kinds of resources, and further development, right?
Mhm. And sorry, I keep interrupting here and saying, another factor, because I worked with a physiotherapist to deliver the program. Um, and I found that having a person who spoke, just to reiterate Sadaf's presentation, that having a person who speaks the language was so important, because there I was, um, on the side trying to show the proper way and such of exercising and such, and not knowing the language. Very different. Whereas with the physiotherapist who spoke Urdu, people just were able to understand, and all these, and she was able to kind of relate some of the real life. And so I think with developing a program, if people are thinking of, making a culturally sensitive program, um, trying to find an instructor who does speak the language will be a challenge. Yeah. But it really is worth it
Hmm.
to go to that
Hmm.
effort.
You had a few champions in the program. Um, would those, just curious if those champions would be interested in kind of doing that peer leadership and taking on any of those pieces of the program, whether it was kind of some of the education awareness pieces or the actual exercise pieces.
I think I'll jump in. We should raise our hands, but now I'm just jumping in. Sorry about
No,
that.
that's fine.
But yes, that Shelley is something that we've been talking about because of also how do you sustain something like this, right? Like to find in there's so many language communities and migrants can experience a lot of challenges and barriers to mainstream programming. So if we were to sort of adapt some mainstream programming to meet their needs, could community champions play that role versus finding a physiotherapist or a registered nurse who speaks the language to deliver? It would be more cost effective. It would also be building on existing community resources and agency. So I think that's important. The question that remains for me, and this was a really small pilot, we really looked at this as a co-design process. We haven't really done this on a bigger scale. We're starting to think about that. But one of the challenges is the older adults who maybe have our lower socioeconomic status, are maybe newcomers or might have their migration status might be temporary as well. They have major challenges accessing healthcare and then even accessing things like physio. So they really, the benefit of having that physiotherapist there was the ability to like tailor a movement to their specific needs, give some of that one-on-one individual coaching, respond to individual questions. And in any class, a physiotherapist or an exercise instructor would do that. But in this context, you might be interacting with older adults who actually don't have any other avenue for support. So it's so much more meaningful when you have an older adult who says, I haven't seen a doctor in 2 years. I've got this shoulder pain. I want to do this movement. Can you help me? And you can't say, well, go to your practitioner or go to your physiotherapist, because that's just not. So there's a major equity issue there. For this subset of the population. And we're talking about this particular group of older adults are ones that are accessing a seniors, an immigrant serving agency. So they do have socioeconomic challenges and they might not represent the general demographic of South Asians, right? So if you have a South Asian who's been here for 20 years and speaks English and university degree, they're probably joining the YMCA or the rec center. They're fine, right? So we're talking about a particular group of older adults that need more intense attention. So whether community champions are sufficient and we will see the outcomes we want to see, preventing falls, that's for the next study, I think.
And so that means that you will have some further progress. Yeah. And good to hear. There's one other comment from Tina, and it says, I did not know that study presumes shoe wearing in the home as in clinical practice. Most people I talk to do not wear shoes in the house. Interesting. That is a cultural difference with USA, perhaps. So just a comment.
Sorry, I'm just going to jump in. I might have
Yeah.
misspoke. It's not that it's steady takes on the approach that everyone wears shoes at home. It's just that their resources they provide is very much centered on what shoes you should wear to prevent falls. So heel below 2.5 centimeters, like
Yeah.
grippy soles, closed-toed shoes, things like that. But yeah, it a little bit of cultural, but I feel like a lot of people also don't wear shoes at home. But it's hard to pinpoint who it is. So the resources they provide is just overall wear shoes that prevent falls.
Yeah. Which is what we do in Finding Balance too,
Yeah.
as well.
Yeah.
Skip the Crocs and
Yeah,
put on a
exactly.
proper pair of
Sports
shoes.
mode,
But
you have to do that
if
way.
that's not culturally appropriate, then
Yes,
yeah,
exactly.
need to explore other components, right? So
Yes.
Great. I don't have any other questions that have come up. So I just want to thank you all for sharing your program and your time with us today. And I think it's very exciting, your learnings, and I hope your paper gets published and shared widely. And I look forward to hearing more about this strong program as it forges ahead in the future. So thank you all very much. Just in closing, just for participants to know that you can obtain a variety of resources from our Finding Balance Alberta website. And on the left here, we're showing our new Actively Aging resource, as well as Spot the Hazard, a home safety checklist resource, everyday exercises, and our band exercises for older adults. So those are all in stock if you're looking for some more resources to support your older adults community in falls prevention. So I think, yeah, thank you again for attending, and visit our catalog if you're going to order. And we'll be sending out a survey, as well as the survey is now attached in the chat box for you to complete.